Hello, we are welcoming back the fabulous Dr. Elizabeth Jackson. Today, we want to cover a couple of things, but predominantly, I'm going to be looking at PMDD. Can you just tell me, what's the difference between PMDD and PMS?
PMDD is Premenstrual Dysphoric Disorder and PMS is Premenstrual Syndrome. The difference is the impact it has on your life. It's common for people to know that they have their period coming up, and these symptoms are driven by the fall after ovulation in your progesterone, but particularly your estrogen. And PMDD, as opposed to PMS, is where it's not only physical, it's psychological. It's really pervasive of your life and how you function. Additionally, it's got a specific criteria as per the DSM-5 criteria. It's something that the more we talk about, the more we realise how many women are impacted.
I know that I've definitely got a couple of patients who they've tried everything. To help me and perhaps our listeners and our patients out there, what's actually happening hormonally? You mentioned about the progesterone. Is it a sensitivity or is it normal? Is it an abnormal?
It's not about the progesterone. It's all about the estrogen. So estrogen, I describe the fluctuations like big wave surfing as opposed to a placid lake. PMDD occurs after a woman ovulates, you reach your peak estrogen level in a cycle, and then that slowly declines in the 2 weeks from ovulation until your period. What happens with PMDD is that in addition to the estrogen levels falling, there is very commonly an underlying vulnerability that impacts you such that when you are ovulating, it profoundly affects your life, your relationships, your work, more than what would be within the realms of normal ups and downs of life. So let's look at when women aren't ovulating, PMDD and those hormonal fluctuations and symptoms when you are on the pill and you're not ovulating, when you are menopausal and not ovulating, when you are pregnant and not ovulating, when you are lactating or breastfeeding and you're not ovulating. Those are states of really placid lakes with your estrogen, and the resolution of symptoms in those states really attests to the impact that ovulation has on women. The big thing is it's about the fall in your estrogen. As we all get older, particularly when you hit your 40s, your overall estrogen levels reduce. As your estrogen levels fall, every time you ovulate, you're going to hit the normal estrogen level, but the fall is greater. So we see in women that have maybe completed their families, their partner's gone and had the snip. But basically, if you're seeking sterilisation methods, you're no longer hormonally managing your contraceptive needs. Babies themselves are a great contraceptive and you're not on a hormonal contraceptive. What we'll often see is that you unmask these underlying conditions. And particularly as you hit your 40s, it's a run up to what menopause is like. So it's like having a mini menopause for many women with the disturbance it can cause to how you live your life.
You think it's been misdiagnosed?
Absolutely.
Over the decades, centuries, generations, I think of how we treated women in previous generations. Certainly in the menopause or perimenopause, women were prescribed tranquilizers and benzodiazepines for that sort of flare. We avoid this. Is it just raising awareness? Do women need to know about it?
So there's several ways to go about it. To be forewarned is to be forearmed. Knowing if you have a regular menstrual cycle, when your vulnerable period is, target lifestyle measures, try and avoid making decisions that may be particularly stressful. Alternatively, you can consider making arrangements with friends to go for walks, go for a coffee, go for a chat. But you want to avoid at the time of the symptoms occurring, which is most commonly peaking a week before your period, a lot of alcohol consumption, staying at home, not socially interacting. Really get out and about with your favourite things to do in life. Another way you can go is medication. You can target antidepressants. So there's medications such as escitalopram that you can take. If you take it continuously, it tends to be much more beneficial because, as I mentioned, there is a vulnerability to women that are particularly affected by PMDD.
I think it's, as you say, there's a big role for lifestyle medicine. I'm a huge advocate for that. It's like being forewarned. This is what to expect. Having that insight, that validation of, okay, this is the week before my period. I know this is going to happen. A bit of insight and collaboration with your support network. I'm going through this and I've been talking to my doctor, and it looks as if there might be something that we can do in terms of lifestyle, managing your stress, managing your workload, managing the school run, managing everything else that we manage. There is mention of medications, and you talked about SSRIs, which I think often are clubbed together as that sort of antidepressant, but actually they work in many ways, and they're particularly useful for that sort of up and down emotional lability we see perimenopausal. But there's long-term effects with antidepressants that are evolving. Getting that information, knowing that this is something that we can actually characterize, anticipate, manage with a bit of lifestyle. I don't want patients suffering. There are treatments.
No. Oh, yes. And so beyond antidepressants, there's treatments. So I guess one of the first things is to talk about the symptoms. You need to have a series of symptoms to meet the diagnostic criteria. But at the end of the day, if you're experiencing cyclical symptoms affecting your life, which may include mood swings, you suddenly feel sad or tearful, sensitivity to rejection, if you're markedly irritable, if you're markedly angry, if you have increased interpersonal conflicts, depressed mood, if you feel hopeless. And also, in addition to the anxiety, the tension, changes in your interest in normal activities, difficulty concentrating, feeling really tired. There's a physical component to it as well. You may lack energy, go off food, overeat, sleep too much. You may sleep too little. You may feel overwhelmed or out of control. You may just get additionally the breast tenderness, the swelling, the muscle pains. So there's all this whole constellation of symptoms. It's a very specific criteria to meet the full diagnoses. But look, in addition to lifestyle measures, we discussed antidepressants. Really at the heart of this is an estrogen thing. I think the fall in your estrogen. There's two ways to hormonally manage it, apart from those other two things that we discussed about lifestyle and antidepressants. The two things that manage it are either reducing the fall in your estrogen, which is basically taking some form of HRT. As I mentioned, it's like a mini menopause. So you could go on estrogen patches, tablets, creams. But I would only go to a doctor for the prescription of those because they need to be very safely managed. You don't get endometrial cancer. But then the other thing you can do is, you know what, don't have the fall in your estrogen. How do you achieve that? You achieve that through turning off your ovulation event. You only need to have a period to have a pregnancy. Biologically, we have confirmed generationally with women, you do not need to menstruate. Men don't menstruate, menopausal women don't menstruate, pregnant women don't, premenstrual women don't menstruate. So we know it's safe to not have your period.
I love that you're saying this because I will often have patients who come in who are really stressed by the process of not menstruating. Be it PCOS, they're taking progesterone-only contraceptives, Mirena, Implanon, etc. It's almost like the yearning for some sort of natural cycle.
The community really don't know this. It's very uncommon to find any female doctor that will have a period. I think people need to know this because to thyself be true. The reality is I don't know a
100%.
gynecologist that has a period. It's not to say that if you want to have a period, go for it. Whatever you want to do, you do. At the same time, I think as not only providers but consumers of medical care, female doctors, we usually don't have periods. Take control.
This is
It's your body, it's your choice. And it is safe to skip your period. You only need to have a period to have a pregnancy. Nature is beautiful, but she is cruel.
As long as we are protecting the endometrial lining and not allowing excessive overproliferation of that endometrial lining, we are pretty safe.
If you look at the cohort of women that are on the pill, There's a few that people don't talk about the benefits of being on the pill very often. You have less chance of ovarian cancer. You do not develop cyclical anemia. You're not bleeding every month. You have more energy if you're not having to replace your iron. But additionally, if you look at fertility, the internet is absolutely full of complete BS. If a woman is on the pill, you are more likely to be more fertile when you come off it. When you come off the pill, your fertility peaks for the next 3 to 6 months. So really consider staying on your contraceptives until that point. But I guess just circling back to PMDD, choose your choice, you do you, however you wish to do this. You can do it lifestyle, you can consider the role of antidepressants, you can supplement your estrogen so your fall in estrogen isn't so great. Why have a fall at all? Very safe to skip your period, to not ovulate. You can achieve that through the combined oral contraceptive pill. Yes, you can be on the oral contraceptive pill in your 40s. Alternatively, there are medications such as Slinda, which is licensed for use for women up until their late 40s
fairly
and early
new
50s.
thing here in Australia. We had similar medications back in the UK that were fairly widely used. Slinda's had a massive uptake. Patients love it.
A small number of women will experience acne. Approximately 3% of people will have hormonal side effects. They can include any progesterone, like any hormone, in your body, with your uterus, with your ovaries. Your hormonal therapies may have its own unique thing. Just because something happened to your mate or your sister or mum, it's not their uterus. Your body is yours. So it's worth considering trialing these therapies. And some women bring on anxiety. It can bring on weight gain. It can bring on weight loss. Any hormonal therapy can do anything to anyone. However, it occurs in 3% of women. So that matters 100% if you're one of the 3%. But if you're not, this is a valid option. Slinda, as well as Vizan, there's other options too, that like Rayco, or Ryeqo, Rayco. It induces actually a hormonal menopause, which is reversible, but it simultaneously gives you estrogen and progesterone. This is not the licensed use for it with the PBS, but it is profoundly effective at the treatment of this condition.
Interesting. When you're navigating this with patients, you have to try something. If it's not for you, you'll know quite quickly.
3 months with these medications translates to years of management of the condition. Many women on a Mirena intrauterine device will not only manage menstrual conditions such as heavy or painful periods, it will also turn off ovulation. If that is you, not quoted as very high, but it's got to be more than what it's quoted.
I often say 10%.
No,
You think 60%?
It's got to be 60. I think many women it turns off cyclical symptoms. There are some women where it doesn't. So I wouldn't go as far to say at all that it's most women. The Mirena isn't designed to turn off your ovulation. But for some women, the little bit of progesterone in it, which is so small, may be enough to interrupt that ovulation event. That means you won't get endometriosis symptoms, you won't get PMDD symptoms, your PCOS will equally be controlled.
And I suppose I'm going to go back to this idea of we can take control. I'll often say this to patients, that the combined oral contraceptive pill, which has been around now for decades
since the
and
1950s.
The design of it, that you had this withdrawal bleed, designed to mimic.
It's so 1950s. Little ladies would like to have a period, like designed by men. It is ludicrous that you need to have a period. It's absolutely bizarre. Skip your period as much as you possibly can. If you get breakthrough bleeding, pause your pill for 4 days. If you can't skip your pill and you're on a standard dose 30 microgram pill, let's say you're on a 20 microgram pill and you are unable to skip your period every month. That pill is not stopping you from ovulation. This is where you hear stories of women falling pregnant on the pill. You need to be on a stronger dose pill. In the 1950s, 60s, 70s, it was only a 50 microgram minimum pill. And we then learned that many women can be controlled on the 30. These days, women are put on 20s, often in their teen years. The body's urge to ovulate is the most strong in your 20s. The need to start on a 20 microgram pill in your teens is just extraordinary to me. Really start on a standard pill, start on a 30 microgram. You shouldn't be on the pill if you get migraines, particularly migraine with aura. If you're over 35 and you're a smoker, you shouldn't consider alternate therapy if you're on the pill and your BMI is a bit elevated. All the GPs are just fabulous. And in Australia, we're very lucky that our GPs are comprehensive in their knowledge and their capabilities with managing women's health. But let's just say that you can't navigate that space with your GP. For example, I'll get many women that have a very trusted long-term male GP, and the boys are brilliant. But sometimes women just would rather, for that one issue, nudge their way through to maybe talk to a specialist. Specialty services within most regional towns in Australia, like true reproductive health clinics, sexual health clinics. If you didn't have the access and the affordability to see a specialist, come see a specialist. If you really can't get a straight answer, please don't Google the internet. Facebook is like asking the drunk in the corner of the pub what they reckon. Please don't do it. Talk to your doctor. Trust your doctor. Care for women. We really want to help, and we can help.
Dr. Liz Jackson, you're an absolute powerhouse for obstetricians, gynecologists, women's health. I'm so incredibly grateful for your wisdom, friendship, and everything that you have brought to this podcast today. Thank you very much.
My pleasure.